where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning and welcome everybody to UroNurse. I'm your host, Vic Senese. Nice to have you here. Hey, if you haven't liked and subscribed to the show, please do. I'd really enjoy it if you did. All right. Today, we're going to have a great show for you. We're going to talk about opportunistic pathogens, which are everywhere in the healthcare environment. And when conditions are just right, they can become dangerous. In this episode, Julia Frith, doctor, nursing practitioner, and Melissa Fortin, doctor, nurse practitioner, break down what opportunistic pathogens are, where they thrive, and why they pose a serious risk to vulnerable patient populations. Now, this is one of our combination collaborative things with the My MCE group. It's a 1 AMA or AAPA or ANCC contact hour program. So you'll be able to get that 1 credit after the show for free. Just go to the link that you can follow on our website on uronurse.com. There'll be a little yellow box to click and just go ahead and click that. You'll have to fill a few things out, get to the post test, and you'll be able to get your contact hours. So let's let them roll right now with the show.
Hello, my name is Melissa Fortin. I'm a nurse practitioner at the Norton Infectious Diseases Institute in Louisville, Kentucky. And today I'm going to talk about opportunistic pathogens in the healthcare environment. Julia Frith is the manager here at the Clinical Research Development and Support. She put together much of the slides, but she will not be speaking today. Funding for this presentation was provided by the Kentucky Department for Public Health. There was no commercial support, and neither Julia nor I have anything to disclose. By the end of the presentation, I would expect you to be able to identify opportunistic pathogens, describe where opportunistic pathogens can be found in healthcare facilities, list infection prevention and control strategies to decrease the spread of these opportunistic pathogens, discuss clinical manifestation of Aspergillus, NTM, and Serratia, and describe some of the diagnostic challenges with some of these opportunistic pathogens. So what are they? First, we have to define what is an opportunistic pathogen. Well, pathogen itself is anything that can cause an illness or disease in humans. And these opportunistic pathogens can be a bacteria or a fungus. Again, they have the potential to cause illness, but they typically don't cause any sort of infection or any symptoms in people that have an intact working immune system. I do want to point out these are not enteric, so these are not germs that could potentially cause us to have like vomiting and diarrhea. These are causing different symptoms. And these pathogens are usually everywhere, not just in hospitals. They're in dirt, the soil, they're in dust, in water. They're all around the environment. So we're exposed to them all the time. And they really are going to impact people who have an immune system that is compromised in some way or isn't able to respond as the way we would want it to. People that have underlying health conditions are also at risk of developing infections from these pathogens. Now, within the healthcare environment themselves, where do we find this? Well, this can also be in dust or dirt. It can be on or in the medical equipment. We see it in sinks, in drains, shower heads. It can be on any of the surfaces in the environment, within a hospital room or in a doctor's office. It can also be on the hands of healthcare workers. We know that healthcare workers can carry infection or pathogens from patient to patient, which is one of the reasons that we stress cleaning our hands. Again, the common causes, going to be not having clean hands. It can be just in the environment. Can be from contaminated items that we use, and can be splashes. I mentioned this can sometimes be found in water. So any splashes. Now, when we think about dust and dirt in healthcare, it's going to be the same as at home. You're going to get dust and dirt on baseboards in the corners. You might get it up higher towards the ceilings or on light fixtures. You could also have this dust or dirt kind of spread up when people are doing construction or renovation, we can sometimes see this in plants, and people bring plants into the healthcare environment. That soil can carry some of these pathogens. Water sources. So what we think of typically are going to be our sinks, the drains, any dead legs and plumbing, shower heads, water fountains, or any sort of water decorative water features in a healthcare environment, and things like humidifiers that can be used when we use humidification for breathing treatments. Now, this just showed an overview of devices in the hospital that contain water. So these are things, if they contain water, there's that potential to carry pathogens. And so we think of things like the heater-cooler units or heater-cooler devices that are used in cardiac surgery, hemodialysis equipment, incubators, fluid warmers, nebulizers, water traps, bathtubs. Bathtubs are used in some healthcare treatment, and of course that can be a source for these pathogens as well. And some pathogens are able to form a biofilm. This is a picture of the internal water reservoir of a heater-cooler unit or heater-cooler device. Biofilms are, unfortunately, they're really hard to get rid of. And it is when bacteria or some sort of pathogen is able to form an extracellular matrix. They kind of form a surface that makes it really difficult for antibiotics, antifungals, cleaning solution to penetrate, but it allows whatever those pathogens are under that film to proliferate. So they're able to survive, and it's really difficult even when we're given the appropriate medication to penetrate that biofilm. And so what do we do to prevent transmission in the healthcare setting? So in the healthcare setting, we have construction barriers. Anytime there's going to be construction or remodeling done in a healthcare environment, it's important that we have a healthcare construction plan. This ideally can be done with several people from the facility, infection preventionist, whoever the construction foreman is. Sometimes folks with engineering. It can be a lot of people where we talk through what is going to be done, what are the potential risks that are going to occur when we do construction. Do we have a plan if one of these things happen, and how do we prevent these things from happening? So you'll notice if you go to some places that have construction going on, they'll have the plastic barriers to prevent people not only from going into an area where construction is being done, it will prevent some of that dust and all the dust and things from coming out into the area where patients and staff are working. They also can sometimes have sticky pads. So if a worker leaves that construction area, any of that dirt can be captured on that sticky pad so that it's not carried around the facility. Some locations and some facilities will prohibit plants from being brought in. Sometimes this will be the entire facility. Sometimes it'll be particular units. They also will sometimes prohibit fans because, again, a fan can be blowing up dust that could cause an infection. When environmental services come to clean a room, when they're doing a thorough clean, they'll clean from the top of the room to the bottom. So they will get up high, clean up high so that any dust and dirt falls down to the floor, and then it's cleaned and removed from the room. Any equipment that we use, we would need to make sure that we're following the manufacturer's instructions for cleaning it. And this will vary. Sometimes you may be using, a ventilator. But if you have two different brands, the cleaning instructions may be different. So we want to make sure we're cleaning it exactly the way we're supposed to, according to the manufacturer. We also need to have water management plans. And this will be done in healthcare facilities. And this kind of identifies any risks. How do we manage those risks? And how do we respond if there is an infection or an outbreak? Also doing things like using single-use items and using care bundles can also help prevent infections or prevent transmission. And then, of course, if this mitigation strategy fails, well, then we have an increased risk of morbidity and mortality. We have outbreaks, invasive disease. We may have to discontinue the use of certain equipment. So let's talk about a couple of the opportunistic pathogens we may run into in a healthcare environment. So first we have Aspergillus. This is a fungus. It has multiple species, and most notably fumigatus. And it's ubiquitous to the environment. It is everywhere. It is indoor, it is outdoor, it is in dust, it's in soil, it's in decaying vegetation, it's in plants. So if you have plants indoor, it has Aspergillus. And it does prefer to feed on dead organic matter for nutrients. It can produce metabolites known as mycotoxins, and it can impair immune function. I began to make a list of all of the ways it impairs the immune system from working effectively, but it works in such a way that there are multiple ways that it tries to evade the immune system. Now, the first outbreak was in late 1970, and it was associated with fireproofing after construction. When we have construction or any sort of demolition, it releases large numbers of spores into the air. Again, why we want to keep that plastic sheeting up between construction and an area where patients or staff may be. Today, about 50% of hospital-acquired Aspergillus infections are associated with construction or renovation. I mentioned already, these are, we run into Aspergillus everywhere. The spores are Conidia, and they're very small, so they travel really effectively on air currents. And these can cause invasive pulmonary infection, allergic asthma, hypersensitivity, pneumonitis, and allergic bronchopulmonary aspergillosis. Now, I'm going to talk about the invasive disease. Many of these others can cause significant symptoms, but most of the time don't require hospitalization. Immunocompromised people are going to be the most susceptible to this invasive disease. And it's characterized by a dissemination of hyphae in the lung and the surrounding tissue. And it is unfortunately one of the most common causes of death in patients that are immunocompromised. For neutropenic patients, the mortality rate is about 50%, and the mortality rate is about 90% for people who have received a stem cell transplant. The most significant risk factor is having prolonged neutropenia, so a prolonged period at which we have insufficient white blood cells. Now, the gold standard for diagnosing this is to examine the lung tissue, which will show necrotizing pneumonia with areas of hemorrhage and inflammation. And the hyphae can actually occlude some of the blood vessels, and then we'll have an infarcted area as well. Now, these are some histopathological samples of an invasive pulmonary infection. And you can see these at 4 hours, we can see that most of the Aspergillus is encapsulated by the macrophage. But at 8 to 16 hours, we start seeing some germination, and then we see the hyphae. And you can easily see how the hyphae progresses over the hours here. Now, serum and BAL galactomannan begin to rise almost immediately. Galactomannan is a polysaccharide that's on the surface of Aspergillus. So when that is high, that indicates that, or when it's present, we know that we have Aspergillus, and as it rises, we have more Aspergillus. So as we see how quickly this progresses, it's important that we identify and begin antifungal treatment as early as possible. When we get to the point where we have a lot of inflammation and there's any bleeding or infarcts, it makes it more difficult for that medication to be absorbed in the lung. Now, I mentioned that the most frequently associated risk are going to be people that have an immune system that's not able to react appropriately. So these will be people that are receiving chemotherapy, people who have received transplants, people that use corticosteroids, patients with COPD or emphysema, and then really any patient in an ICU environment. We have to think, if you're in an ICU environment, the immune system is already working pretty hard, and at that point, the patient is vulnerable to other infections. Now, the symptoms are usually nonspecific. Can have a cough, fever, and weakness, maybe some shortness of breath. In an ICU patient, that's not unusual, especially if they're admitted for a respiratory illness already. Some patients can have hemoptysis or chest pain. Again, most of the time, the symptoms are kind of nonspecific. Now, on the left here, we were talking about what's the gold standard to diagnose, have a definitive diagnosis. Well, we're going to need a culture of the lung. And so what we'd need to do this is to get a specimen from a site that's normally sterile, but clinically in this case is abnormal. So we can't get this from a BAL, we can't get this from a sputum culture. We really want to get this from the lung. We want to get a piece of the lung. If this is something that is spread beyond the lung, we want to get a piece of whatever we think is affected. Now, there are many reasons that we may not be able to get that. We often have patients who are unstable, who may have bleeding issues, or they just may not be able to tolerate having a biopsy. So on the right-hand side here, we have some guidelines about, when do we think if we can't get, the histological sample, what's a pretty probable diagnosis? And this is made up by the European Organization for Research and the Mycosis Study Group. So we have the risk factors, the patient's symptoms. The clinical features in this case, we want to have a CT that showed one of these, at least one. So either lesions with or without a halo sign, an air crescent sign, a cavity, or a wedge-shaped segmental or lobar consolidation. And then we'd want to have at least sputum, BAL, bronchial wash, or aspirate that showed galactomannan, and then an aspergillus PCR from plasma serum or whole blood. So there are things that we can do that would give us a probable or likely diagnosis, but really the definitive diagnosis will be a histopathological sample. Now on imaging, this is the kind of thing that we'll see. So on the left, we have a teen with leukemia who developed shortness of breath and chest pain 2 months after starting chemotherapy. And you can see the nodules there on his CT. And this particular patient required 2 years of antifungal therapy. On the right, there's a little white arrow showing the consolidations and nodules in a 56-year-old woman with lymphoma who was receiving chemotherapy. These are some examples from patients this spread beyond the lung. So on the left, we have a picture of aspergillus in bone marrow. In the middle picture here, it shows a patient with who had a headache. This is a patient who had a history of transplant, and you can see that as an abscess in the CT. So she had a CNS aspergillosis, and on the right, a 21-year-old receiving chemotherapy for leukemia. And the CT of her abdomen shows a jejunal wall hyperenhancement and severe mesenteric infiltration. And so this patient had peritonitis secondary to aspergillosis. Now, the diagnosis is really difficult to make. When we have a patient that's acutely ill in the ICU or a patient that has chronic health conditions and is acutely ill, in addition to the symptoms often being very vague, we don't often think about opportunistic pathogens. We think about a new pneumonia, a worsening of whatever the current illness is. So that's what we typically look for. In addition, fungal and acid-fast bacilli cultures can take a really long time to result. It can take up to 2 months to get results. So what do we do in that 2-month time period? Additionally, when we're looking at a piece of tissue, which is really what we want, we really need a big piece of tissue. And that's not always possible depending on, the patient's status. They may not be able to tolerate that. So kind of the lab sometimes kind of gets what they get. And it might be a really small piece of lung tissue. So the testing won't have as good of sensitivity. And then because aspergillus is everywhere, it's possible that they can contaminate culture plates, which would confound the results. Sometimes the lab will ignore the first culture and get a second culture, but then we're talking about many, many months to get a diagnosis. And I want to walk through a case about how challenging this is, to demonstrate how challenging this is. This is a 1-year-old patient who was being treated for leukemia. And 9 days after he started chemotherapy, he became neutropenic. He did not have a fever, just neutropenic. At that time, his inflammatory markers were normal, but they did begin prophylactic amphotericin B, and they began checking serum galactomannan twice a week. 3 days later, he developed a fever, and at that time, they did a septic workup and started meropenem. The chest x-ray at that point looked okay. His blood culture showed a resistant E. coli bacteremia, so the antibiotic was continued. The blood cultures became negative on day 5 of the antibiotic, and a chest x-ray at that time still looked okay. Several days later, the patient developed another fever, repeated the cultures at that point, also tested the patient for C. diff and CMV. They sent a PCR for Aspergillus and Candida, and they did check galactomannan again. At this time, the galactomannan was positive, and the CT showed bilateral ground glass opacities. At that time, they began IV voriconazole, and they did a bronchoscopy to get a BAL, which was positive for Aspergillus. Now, several days later, the patient had a sudden deterioration. He had a seizure. He was moved to the ICU and had a brain CT that showed an extensive hemorrhage. Fungal cultures from the CSF at that point were negative, but they did add capsulfungin. A brain MRI that was obtained in the ICU showed multiple abscesses. And this patient had persistent fever, so they did a brain biopsy, which did show hyphae. And then gene sequencing did identify Aspergillus. So this patient received the appropriate treatment, and despite that, he did not survive. So you can see that from the moment the patient developed symptoms, which again, the first symptom was just having a low white blood count, they were doing appropriate testing, giving prophylactic medication. So there wasn't a period where they were not doing things. They were testing for fungal infections. They were giving medications. And many of these tests were negative until we got that brain biopsy. Now, the treatment really is, if possible, we want to eliminate or reduce the dose of immunosuppressive therapy. Of course, that's not always possible. And because definitive diagnosis may take a long time, we do want to go ahead and begin antifungal treatment if we're suspecting that. The typical treatment is voriconazole for 6 to 12 weeks. Alternatively, we can do amphotericin B or isavuconazole. Now, during treatment, we'd want to do serial monitoring of the serum galactomannan because we want to assess the response. Now, prophylaxis with voriconazole or posaconazole can be used for patients that are high risk during periods of prolonged neutropenia. And the outcomes that are associated with mortality are patients, of course, who have received an organ transplant, have malignancy or receiving chemotherapy, patients that have COPD, diabetes, or heart disease. And if this spreads beyond the pulmonary cavity and involves the central nervous system, the outcomes are worse. Now, another one is Mycobacterium. Now, we have some obligatory pathogenic mycobacteria that can cause things like tuberculosis, but NTM, or non-tuberculosis Mycobacterium, is a potentially pathogenic mycobacterium. So it's something that can cause infection. It lives in soil, sediment, dust, water, and it adapts really well to the environment. Most of the time, it will transmit via aerosols or inhalation, but it can transmit via water that's been contaminated. It's super slow growing, and it does develop those biofilms that we talked about earlier. The risk factors won't surprise you. It's going to be people that are immunodeficient, people that have chronic or restrictive lung disease like COPD, emphysema, cystic fibrosis, anatomic lung abnormalities, autoimmune disorders, and postmenopausal women. It can cause skin and soft tissue infections, lymph node infections, which are the most common type of NTM we'll see in kids, that is associated with infections of any indwelling device, can cause lung infections, blood infections, or any infection at a site that's usually sterile. And the risk is increased in settings where the patient is in contact with contaminated water. So that can be hot tubs, nail salons, and then of course, anytime we're in the healthcare setting and there's contaminated water or exposure to that water. It's also a risk in patients who receive cardiovascular surgery. And that includes cardiopulmonary bypass surgery involving heater-cooler units or heater-cooler devices, and one or more of the following: prosthetic material used for cardiac valve or aortic repair, mechanical circulatory support device implantation, implants of shunts, conduits, or other prostheses for congenital heart disease, coronary artery bypass, and heart transplantation. There was a large outbreak of NTM associated with heater-cooler units. These were infections, and initially these were seen in people that did not have any immune compromise. In 2011, the two people were found. One had a bloodstream infection and one had an infection of a prosthetic valve. The surgeries for these patients had been performed in 2008 and 2010. Both cases, the patient needed ECMO or bypass during their surgery. Now, as they began to investigate this, they found about 180 cases in countries all over the world. There were 5 manufacturers implicated in this and more than 100 facilities. Now, when we think about a patient undergoing this type of surgery, we have to use a cardiopulmonary bypass. And the heater-cooler unit itself is used to control the temperature of the fluid or blood. So you can see this huge setup here with all kinds of really important things. And the heater-cooler unit is the smaller device up front with the silver top and the black in the front. So this is the thing that kind of controls the temperature. Now, most symptoms here are nonspecific, and they typically don't occur for months or years after surgery. The incubation period is 6 months to 5 years. And on average, symptoms will develop about 16 months after surgery. And a lot of times, extrathoracic symptoms might appear before any cardiovascular symptoms. So you can already see where this becomes difficult to diagnose, because we have a patient who may be coming in years after surgery. The most common symptoms are fever, weight loss, general fatigue, and night sweats. You don't often immediately think it had to be that surgery from several years ago. The physical exam in these patients is often normal. Now, patients that come in and they have a cardiac symptoms, the diagnosis will often include infections of the aortic graft, prosthetic valve, implantable devices. And so these folks may have chest pain or symptoms of a surgical site infection. If this becomes disseminated, it tends to affect the eye or the central nervous system. So when we think about testing and diagnosis, again, there may be some local symptoms like, cough or shortness of breath. We have those general symptoms. A chest X-ray or high-resolution chest CT will show nodular or cavitary opacities, bronchiectasis, and can show nodules. And then from a microbiologic diagnostic, we would need 2 positive sputum cultures, a positive BAL or bronchial wash, or a biopsy that showed mycobacterial histopathologic features. And of course, we want to rule out other other diagnoses as well, like tuberculosis or cancer, anything like that. This is what we would see on imaging. So you can see that the top left, we have bronchiectasis, small and large nodules in B. On the bottom left, there's a cavitary lesion. And on the bottom right, we can see this pretty significant bronchiectasis. Now, the treatment here, unfortunately, is a really long. The patient is put on a minimum of 3 antibiotics, typically a macrolide with ethambutol and rifampicin. The treatment is usually 12 plus months after a negative sputum culture. And within 6 months of completing treatment, 10 to 60% experience a relapse. These patients may require pulmonary resection. They may require surgery to remove and or replace any infected indwelling device like the heart valve. And then, of course, the factors that increase mortality, being a male, elderly, history of tuberculosis, diabetes, heart disease, liver disease, systemic immunosuppression, or anemia. And finally, Serratia. Serratia is a gram-negative bacillus. It's a member of the Enterobacteriaceae family, and we see this in water and wet soil. It can survive in extreme conditions, and it can actually live in disinfectants and antiseptics. It produces lipase, gelatinase, DNase, enzyme, serowetin, and it has a red pigment. So this sometimes we'll see what looks like a mold or something in a shower or near a sink that looks so pink. That's Serratia. Again, in the healthcare environment, we're going to see this. It can be in contaminated saline solutions. It can live in disinfectants. It can live on healthcare worker hands. It can be in tap water, and it easily acquires multi-drug resistance. It's associated with pneumonia, urinary tract infections, skin and soft tissue infections, and endocarditis, especially amongst those who use injectable drugs, central nervous system infections, and eye infections. With an infection of Serratia in the eye, the outcomes are very poor. Most people lose vision in the eye, and about half of them will need to have the eye removed. And so the symptoms of the infection are typical of bacterial infection symptoms. So if they have a urinary tract infection, they'll have urinary tract symptoms. If they have pneumonia, they'll have pneumonia symptoms, or whatever the typical symptoms would be. And so we'll get the same sorts of testing that we would get with anything. So we'll get cultures of blood, potentially urine, sputum, CSF, or body fluid. Again, the risk factor here: immunodeficiency, malignancies, hypertension, COPD, indwelling device, IV drug use, diabetes, any surgical procedure, including LPs and joint injections, and having 2 or more underlying health issues. There was an outbreak of Serratia in a large tertiary care hospital that occurred in the coronary ICU and the emergency ICU. And this happened in 2 waves. The first wave was included 20 cases, and the second wave were 10 cases, and the 10 cases were all colonized. They went around the hospital and they collected cultures from the environment. They did associate these infections with, or these colonization and infections with CRRT use. The 30-day all-cause mortality among those 30 patients, and remember, most of these were colonized, but the mortality was 43%. The pathogens in both of these waves were genetically similar, and there had been an increased use of carbapenems and colistin over a period of time before these outbreaks happened. This shows really where those cultures identified the pathogen, and you can see the bed, the doorknob, closet, refrigerator, around the sink, toilet seat, water purifier, sink, faucet. A lot of it was around water. Now, for the treatment of Serratia, there are no guidelines. Serratia is resistant to a wide range of antibiotics. It's able to express AMP-C beta-lactamase. It can produce ESBL. Some strains can encode carbapenemases. And so the choice of antibiotic is going to depend on the site of infection and the ability of the medication to penetrate that area. Depending, again, on where this infection is, it may require the removal of an invasive device or prosthetic material, drainage of abscesses, or debridement of any infected tissue or bone. So when choosing a medication, we should be looking at the sensitivities and also having an ID consult. They can really help us determine what medication to use and for how long. This showed resistance in 57 cases of patients who had Serratia. The left picture really shows us the list of different medications and the resistance. The lighter color, the darker color is sensitive, the lighter color is resistant. And we can see resistant to almost all of the most common medications. For these 57 patients, the right-hand picture shows what antibiotic was ultimately used for treatment. And it might be a little difficult to see, but the most common medications used were ciprofloxacin, amikacin, gentamicin, ceftazidime, imipenem. Those were kind of the most common that were used. This is a sample of the dosing regimen for a urinary tract infection, and this is taken from the IDSA guidelines for treating not serratia, but resistant gram-negative infections. And it was also used with FDA-approved prescribing information. So you can see the 4 options here that it gives for an antibiotic choice. But you can also see that all of these may have significant potential side effects. So ciprofloxacin can cause tendinitis or tendon rupture, peripheral neuropathy, or CNS effects. But sometimes that may be the only medication that we give. And you can see there's not an end date here because, again, we don't have any guidelines on how long to treat. Again, that's why it's so important to have infectious diseases team and maybe ID pharmacy involved to help us develop a treatment plan. Now, the takeaways really here that opportunistic pathogens typically don't cause infection, but can cause increased morbidity and mortality in patients that have immune systems that don't respond appropriately. They can be found in drains, in unclean medical equipment, and in dust. The infection prevention and control strategies such as hand hygiene, surface cleaning, construction barriers, and water management plans can decrease the spread of opportunistic pathogens. The clinical manifestations of Aspergillus, NTM, and serratia can present like many other infections, or they can be really vague. And opportunistic pathogens can be difficult to identify due to the decreased testing abilities and delayed infectious response. That is all I have for you today. Thank you so much for joining me.
All right. I hope you enjoyed that. This is, like I said, kind of nice to be able to get that free contact hour. So really good show. So be sure to fill out your information that you need to get the contact hour. Just again, follow that link. And hey, coming up next week.
Paraphimosis is a serious urologic emergency that requires immediate attention. And yet many people don't recognize the warning signs until it's too late. In this episode of UroNurse, I break down everything you need to know about paraphimosis in a clear, practical, and patient-focused way. Join me on May 9th at 9 a.m. Central Time to learn more.
Yeah, so that should be a great episode. I kind of look at what things we haven't talked about, and I noticed that we didn't do anything on paraphimosis. And, that's one of those things that I think we encounter. It's usually an emergency type situation, and lots of tips and tricks. Nurses actually can correct paraphimosis if you catch it early enough. So we'll go through all those with you next week. So join us next week. You don't want to miss this episode.